Good evening, everyone. It is Wednesday evening and it's another fertility talk. And welcome, everyone. Thank you for joining. Just going to wait for a couple of guys to come on and then we can start our talk. Hi, everyone. Thanks for joining. Hi. Thanks for joining. As I was saying, Wednesday evening. And Genesis is here, and tonight we are talking about fertilization failure, and it's definitely not a subject I've spoken about before, so we really inquisitive and excited to hear what it is. And it's also the first time we have Robin's an embryologist, and she's from Genesis. So I'm just going to give everyone a couple of minutes to come online, to see that we're online, and then we will invite Robin from Genesis. Robin, I'm going to send you a request now. So thanks, everyone. Hi, Sonia. Hi, Des. Thank you for joining. And I see Solar Blessing is here. Let me just see. There we go. Hi, Robin.
Hi.
Hi, thanks for joining.
Oh, you're welcome. Thank you for having me.
It's a pleasure. It's a pleasure. So tonight we're talking about fertilization failure.
Yeah.
But we're first going to introduce you to everybody. So Robin is an embryologist from Genesis Reproductive Center, and that is in Joburg. Am I correct? Pretoria, yeah. So it's the first time you guys are doing it live with us, and I think the others were all on Facebook. Yeah. So we're very glad that you've joined us this evening. And I'm going to just hand over to you to first introduce yourself and tell us more about what it is that you guys do.
Okay, well, I'm a senior embryologist in the lab. So we do anything and everything that all the other labs do. I'm very passionate about what I do. I love what I do. I'm busy studying multiple master's degrees and all of those kinds of cool things, and I'm very interested in current topics, and I like to think that I'm quite focused on how the patient feels, and I think that's very important to us as well at Genesis. We really like to take, we created the entire atmosphere at Genesis around something that would make a patient comfortable. And we really do like to spend a lot of extra time with our patients. So something like this is, fertilization failure. It's very upsetting, very devastating. So It's something I think is important to talk about because it's very confusing and patients don't understand what it is and what's happening.
Yeah. Great. And I think you're the person that actually, if I'm correct, I'm just trying to put it in layman's terms so everyone understands that embryologist is the person that actually sitting there making sure that the eggs are being fertilized for IVF. So you're the lady that do all those things. Am I right?
Yeah. So once the doctor has taken the eggs out, we are the babysitters. So we sit and we look after them. We do our best to make sure everything goes the way that it's supposed to. And when it doesn't, we do our best to make sure that we still have a good outcome.
Awesome. So we're going to get right to it. We have a few questions for you tonight, Robin.
Okay.
First of all, what is fertilization?
Okay, so normal fertilization, we have the egg and we have the sperm. So we want to see the fusion of these two gametes together. And from that point on, we will then refer to this cell as a zygote. It's no longer then an egg or just a sperm. It's then now a combination of your chromosomes creating a unique embryo. So when we do this, we have to do it under a microscope. So we do this the day after we've retrieved your oocytes. We would perform either IVF or icsi, depending on what is indicated. And then either, somewhere between 16 to 20 hours, we would then do the microscopic evaluation. What we're looking for is in that nice big round oocyte, we want to see two little indents, and then inside them some little speckly parts, sort of like speckled eggs. And that would be a successful fertilization. Two pronuclea is what we will call them. One will be from the mother, one will be from the father, or from the egg and the sperm. And then there are other indications of fertilization. So we have our big egg, we have our two little pronuclea in the middle, and then we also want to see two little polar bodies, which are sort of like these round little cellular droplets on the top as well. So that would be successful fertilization. We get cases of abnormal fertilization where we would only have one pronuclear or no pronuclear or more than two pronuclear, like 3 pronuclear up to, I don't know how many people have seen 7, 10. I've seen at the most, I think, about 5. And that would now be something we call polyspermy. So that's abnormal fertilization. In the case where that happens in IVF, we would assume more than one sperm has entered the egg. In the case of icsi, we know we've only put one sperm inside, so then we assume it's an egg problem where an egg is carrying an extra load of chromosomes. So that is what fertilization is, what we look for, and then how we would classify it. So we want to see 2 pronuclear, 2 polar bodies, and the pronuclear would be from the egg and from the sperm.
Okay.
Does that make
Wow,
sense?
that's a mouthful. I promise you, I try to keep up with exactly what you're saying. Okay, that's that. But I think I'm getting some part of it. So basically, it's the egg and the sperm.
The stage of fertilization, it's sometimes missed in labs. So when I say we observe it between 16 and 20 hours, that would be standard protocol in a lab, but it can be missed. We do have eggs where it happens earlier, and eggs that are maybe in older women where fertilization happens later. Obviously, these fall outside of the normal parameters. It does not mean that it's a poor prognosis, there will be no pregnancy, anything like that, but it can mean that there may be other problems down the line. It's not a death sentence, but these things do happen, and we do sometimes miss it. So it's not the end of the road if that does happen.
Yeah. Okay, great. Okay, what is the factors that affect fertilization?
Okay.
And if I may ask something extra on that, would these factors occur before, going for the IVF treatment? I'm sorry to throw that in, but I mean, it's just a question that would it have, these are factors that would it affect before, or is it something that happens, once the procedure's been done and things like that?
So because the whole process of fertilization is really, really complicated. I mean, we have a multitude of cellular activity that is happening, not only in the egg, but with the interaction of the sperm and the egg. So there are problems that could have happened in, the female before she's been stimulated, fundamental problems in how the eggs were formed that could affect the way fertilization happens. As the same happens in the man. If we have sperm that has a poor DNA integrity, where the DNA inside the sperm head has not been condensed properly, then we're going to have a problem. And those are things that happen during spermatogenesis, which is before we get to IVF and icsi and all of those things. So yes, that can happen, and we do have cases where after going through everything else to eliminate what the cause is, that we find that there is a fundamental, so to say, genetic reason for what is going on. Factors influencing fertilization in the lab, obviously there's 4 main factors. So we've got your lab and your embryologist. So you need to have skilled staff, and you need to have a good lab. So the culture conditions, the temperature, the pH, all of those things, big factors. The other 2 main factors are obviously your egg and your sperm, because they're the 2 principal members of the party that's happening. So, when we look at fertilization factor, it's so difficult to say. I hate it when patients play the fault game, and I know they're going through something that is so difficult, and it's never really entirely one person's fault, because when we talk about fertilization, it's like one hand helps, the other hand helps, it keeps going like that the whole time. If the egg doesn't have these things, then it can't help the sperm, and if the sperm doesn't have those things, it can't penetrate the egg. So it's really complicated. If I break it down to you in the sense that you had a talk with a doctor a week ago, I think, about the difference between IVF and icsi. So IVF then being where there's natural selection, where we put the eggs in a dish and the sperm then penetrates on its own, and icsi, where the embryologist selects the sperm and injects it one by one. So there's about 6 processes involved in fertilization, going from IVF, 3 of which we would bypass if we go directly into icsi. So the sperm needs to interact with the cells that surround the egg. In order for that to happen, we need to obviously have a good sperm concentration, which would then be why we're doing IVF. We need to have good semen parameters and a young patient without any other complications. And the sperm needs to have the right molecular components for all of those interactions to happen, for it to find the cells around the egg, for it to find the egg, and for it to bind to the outside of the egg. But on the other hand, the egg also needs to be releasing certain factors to draw the sperm in and to allow for the breakdown of the cells so that the sperm can get to it. So again, you've got 2 hands that need to hold each other and get through it together. If we bypass those parts and we go straight into icsi, we are removing the cells around the outside of the egg. We're removing the fact that we need a sperm to swim towards the egg and that it needs to bind, and we're just pushing it right into the egg itself. From that point on, an oocyte needs to be activated. So the process of icsi, because it's a mechanical process, that process should sort of activate the egg, and you sort of give it like a nudge in the right direction and say, hello, okay, let's wake up, it's time to do something. And then through that, the sperm head will then decondense and form its pronuclear, and the egg will then also form pronuclear, creating 2 pronuclear, which would be successful fertilization. But like I said, if there are now problems with the sperm and it cannot decondense, or if the egg cannot activate, then we're not going to have this process happening.
Yeah. Okay, well, okay, that is actually, you explained it so well. Thank you very much. That was really well. Okay, this one is a bit of a mouthful. Is fertilization failure or suboptimal fertilization more predominant in IVF or ICSI?
Okay, so fertilization failure or suboptimal fertilization. So suboptimal fertilization will be anything that's less than 50% fertilization. In the IVF lab or the reproductive lab, we want to see ideally 70 to 80 to 90% fertilization. That is normal. IVF, ICSI, it shouldn't differ. Obviously, in certain patient subgroups, we will have a slight deviation because we're going to have other external factors. But IVF would generally be the one where we would see more fertilization failure and more suboptimal fertilization. The reason for this being, patients come in with a good prognosis. You have a woman that is younger, she responds well to the medication, her endocrine function and her hormones, everything looks good. And we have a man who goes for a semen analysis and it comes out normal, there's no red flags, there's nothing. So we get to the IVF lab and we say, okay, there is no reason for us to do ICSI for the extra expense, for the extra exposure in culture time and manipulation that's involved during ICSI, so we would do IVF. However, there is, of course, the chance that this is not going to happen because the fertilization won't happen, because we cannot see all of these little intricate molecular things just by looking at a dish with eggs and sperm in it. I wish we could, but we can't tell what's going to happen. If everything looks normal, everything should work out. So fertilization failure in IVF occurs only in about 5 to 10% of patients, whereas in ICSI, a total fertilization failure where we've had mature eggs, we've injected them all with a sperm, would only occur in about 1 to 3% of patients. And this because we know we've definitely got a sperm in there. In IVF, if we have fertilization failure, 60 to 90% of the time, it will be because that little sperm didn't get into the egg. And then we know we've got a problem getting through all those cells and we need to help it get in there. Even though we've got a fantastic sperm count and everything is swimming and the morphology is great, there are just some things we can't test for and we cannot see on like from the get-go. And we need to
Yeah.
do this process to get there. And IVF and going through this journey and everything, you know, it's a learning process for the doctor, the embryologist, and the patient. And it
Yeah.
sucks because
Yeah.
it's repetitive cycles and it takes a while to
Yeah.
get there. But we have
Yeah.
to learn and we have to do a process of elimination to find the best way to handle it.
Okay. What I'm hearing from you is that, oh, what I also, when I spoke to the other doctor and we did the talk on the icsi and the IVF. In your opinion, I'm not saying that people must go according to what you're saying now exactly, is that, but in your opinion, if you were in that situation, would you spend the extra money on rather doing the ICSI because it's a better result? You could have, there's a better chance. I hope I'm not putting you on the spot answering that,
No,
or would you,
it's a
or
very
would you
common
rather,
question.
do the IVF and just see if it works first time, that type of thing, and save that money? What would you do?
You know, there are many labs in South Africa and in the world that only do ICSI because they want to avoid the situation of fertilization failure altogether. And you know,
Okay.
that's fine. Whatever works for you works. But me,
Mm.
myself, and at Genesis, we firmly believe in IVF. I've had patients who've had really poor semen parameters, and we've done ICSI over and over and over, and it doesn't work. We do IVF once, we freeze embryos, and I've got a healthy baby boy and a healthy baby girl from that. And that's all just through IVF. Um,
Oh,
you know, you have an embryologist that's choosing the ideal sperm for you. And
yeah,
we can't tell just by looking. And we have very fancy tools, don't get me wrong.
yeah,
We've got really
yeah,
cool stuff in the lab, but that doesn't always give us all the answers that we're looking for. Natural
yeah,
selection is ultimately better than an embryologist because it's the way that nature intended it. However,
yeah,
if you have definite problems, and if you have a patient who's, let's say, over the age of 38 and she has, you know, a poor AMH value and, you know, a lot of things that are looking like, you know what, we're not going to be able to do a lot of cycles here, we don't have
yeah.
time to waste, then I would definitely do ICSI. If we've only retrieved 5 eggs and we've got an older patient, I would definitely do ICSI because I
Okay.
don't want to waste their time,
Yeah,
and I don't
that's
want to risk it.
yeah. That is such a great answer. That is so. What I'm hearing is I'm not just hearing the clinical side of you or the almost like doctor type side of you. Is I'm actually hearing like I'm talking to another woman that actually understands the emotional side of infertility and going through the process of going through fertility treatments, and if it works, it doesn't work, it costs, the emotional side, everything about it. So that is great to hear that answer. Thank you.
Okay.
If it happened once, will it happen again? Fertilization failure. Doesn't mean it would always happen.
It won't always happen.
Yeah.
It could happen again. The chances are very slim. So, like I
Yeah.
said to you with the different IVF labs, so we would all have protocols in place for what to do when it goes wrong. So
Yeah.
if we have a patient who's come in, we've done IVF, we've had poor or failed fertilization, we've done an ICSI, we've had poor or failed fertilization, we're definitely going to look at what else can we do to make this better, to help you and to get you that baby that you want. So
Mm.
there are different options, and there are different ways to approach it. And it's really, you know, how I said the one hand helps the other hand in the process of elimination. And, you know, there are ways to follow through. So the first thing would be to make sure that we're activating that oocyte properly. So that would be
Yeah.
either using a medium that's rich in something we call calcium ionophore. So there are mediums on the market that have that in them that assist for patients where we have this problem, and then we use it during the ICSI process. There's also mechanical activation and electrical activation or stimulation. So depending on where you go and what the lab has, the kind of skilled staff that they have and the equipment that they have, that is what they will do. But they will definitely always do their best to do one step better, because we cannot keep doing the same thing. We have to improve.
Yeah.
So the chances of it happening again, very, very slim. I think, if I'm correct, it's probably less than 10% that it would happen again.
Wow. Okay. Great. Okay. The last question I have for you: Do fertilization rates differ for patients with PCOS? Yeah.
Okay. Yeah, so being PCOS Awareness Month,
Yeah.
PCOS patients, as with any other patient, are a unique demographic. So we struggle to stimulate them. Sometimes we get, I don't have a word for this in English, an ontploffing, where,
Okay.
you would start at a certain level with the stimulation, and then all of a sudden there's all these follicles, and we get like 20 or 30 eggs.
Yeah.
But the biggest problem with that is we usually, almost always, have a high amount of immature eggs. So fertilization failure or suboptimal fertilization does not differ if a patient has polycystic ovaries. However, it definitely feels like that to the patient because, when we phone them the next day and we say, okay, we retrieved 20 eggs, we've got 11 that fertilized, they go, oh, what happened? Did the rest die? And we go, no,
Mm.
they weren't mature or they weren't ideal
Yeah.
for the icsi process. But, again, with the different protocols in labs, what we do at Genesis, we keep them until the next day and we would inject them the next day if they're mature. And sometimes we inject the immature ones as well. And we've actually had results from that as well. So it really depends where you go and what the lab is comfortable with. The most important thing is to trust your lab staff because they do know what they're doing. If they're
Yeah.
there,
Yeah.
they know what they're doing.
Yeah. Yeah. Wow. Okay. That's absolutely great. Thank you very much for this talk, Robin.
Oh,
It
sure.
was so nice to hear from somebody that's actually the the babysitters to actually hear from the babysitters. I always hear people talking to you, talking about you guys as being the first babysitters. And but yeah, you guys are doing a great job, and I'm hearing such a lot about Genesis. So, Genesis, can you just give us some details of where Genesis is, how to contact Genesis as well?
Okay, so Genesis is in the Kloof Mediclinic in Pretoria East. So I can drop in the comments a link to our page or to our website, and then we're easily contactable. We don't do appointments via email or anything. Phone us, ask to speak to one of the friendly nurses. They are usually very nice to everyone. No, I'm lying. They're always very nice to everyone. And then we will direct you to make an appointment with one of our specialists. So we have 3 doctors. We have Dr. Deo, we have Dr. Aubrey de Bruin, and we have Dr. Dries Potgieter, who are working at our unit.
Okay, awesome. Thank you very much, Robin, and hope to have you back soon on another talk. Have a great day further.
Oh, you're so welcome. Thank you.
Thank you. Bye.
Bye.